All right, good morning. It is the last day of January, January 31st. This is Senate Health and Welfare. Tomorrow is Rabbit, so it'll be on the way. So this morning we've got we're doing some work on some of the mental health bills in front of us. And I did see Maureen Fox here, yes, okay, good. He should also be on the agenda. So we're going to start out with a competency restoration report, and is Karen going to do that, or? Yes. Good morning, Karen.
Good morning.
So, I think it would be helpful if you might frame where the competency restoration report comes from. We did ask for that in legislation, so that would be helpful. If you don't mind doing that.
Absolutely. Yeah, I was thinking after last time it may be helpful to kind of level set. So I'm happy to go through that. For the record, Karen Barber, General Counsel for the Department of Mental Health. I wanted to first kind of make clear that a policy for competency restoration isn't dependent on a forensic facility. Competency restoration can occur in a variety of settings, and as the report noted, best practice is to have it across various different environments, including DOC and treatment settings, both inpatient and outpatient. So while you could make the policy decision to do competency restoration at a forensic facility, the two are not necessarily linked. So I just kind of wanted to make sure we were all kind of starting from that place.
Yeah, thank you. That's an important clarification.
Yeah, the other thing I wanted to kind of, as you were talking about, so competency restoration currently does not exist in Vermont. And I thought it might be helpful to kind of review what happens now so you can understand why we're talking about competency restoration. Would that be helpful?
Yes, please.
Okay. So right now we have a civil mental health system and a civil intellectual disability system and a criminal justice system. They're two very separate systems. They do overlap, but they don't fit neatly together, right? Because they're designed to do very different things. And so last year, the legislature spent a lot of time talking about some of those gaps, and Act 28 made really some big beneficial changes to that, but there's still a couple kind of gaps in the system that we're seeing. So right now, anyone can raise the issue of competency. And competency is a threshold issue, meaning you can't proceed to trial unless a defendant is competent to do so. And competency is basically the ability to understand the charges against you and to work with your attorney. It's important to note that competency is not a clinical term. It's a legal term. It could have nothing to do with mental illness. People can be incompetent for lots of different reasons. It could be mental illness. It could be an intellectual disability. It could be TBI. It could be dementia. It could be substance use. So right now, if an issue of competency is raised, DMH is asked to do a neutral evaluation. So we spent a lot of time on kind of tweaking that system last year, but basically we have about 14 evaluators that we use, and they do these evaluations. Their decision on competency is not dispositive, meaning it's not the end all be all, right? So they say, based on their clinical expertise, they think the person is either competent or incompetent. The defense or the state's attorney can get their own evaluation, and they can ask for a contested competency hearing. So they can say, I don't agree. We want to argue about whether or not this person really is competent or not. And ultimately, the judge is the one that makes that decision. And so once a decision has been made, if a person is found incompetent, that's where we see some of the gaps in the system, right? So by statute in Vermont, there's a limited amount of time that someone who has been found incompetent can remain in corrections. So the question is, where do they go? If someone is incompetent and has mental illness that is of such an acuity that they would be appropriate to be in DMH's custody, then they may go into our custody. That could be on an order of hospitalization if they meet hospitalization criteria, or it could be on an outpatient basis on an order of non-hospitalization. Remember that being in our custody is tied solely to someone's clinical needs, and they're only in the level of care that's the least restrictive for where they're at. So they would never just remain in a high level of care. The goal is to always transition them to lower level of cares when it's clinically appropriate. If someone doesn't meet that level of care, there's no secure setting for them. The other thing is people can and are dangerous for reasons, lots of reasons other than mental illness. So if someone is in DMH custody, there are some secure settings, but they will continue to transition through those settings. Dale doesn't have any secure settings. There's no kind of involuntary treatment for substance use. So there's a real question about what happens if someone remains dangerous for reasons other than mental illness or doesn't meet that criteria. Where do they go? And that's what the forensic facility is kind of talking about. The other issue and what competency restoration about is that if someone's found incompetent in Vermont, we don't try to restore them. So most states have programs where they say, okay, if you're incompetent, we're going to work to get you competent. So either you can argue and be found innocent of the charges against you, or you can be held accountable. In Vermont, that doesn't happen, right? There are some cases where mental health treatment may result in a restoration of competency, but that is not the goal of treatment. We don't actively try to restore them to competency. We're not considering whether or not they're restored to competency. It may or may not happen. So that's how we kind of got here, is there were some discussions about should Vermont have a program that does focus on competency restoration. And so that's why we were asked to kind of consider it. And so the report we gave you was our attempt to kind of look at what other states are doing, look at the clinical evidence, and then if the legislature made a policy decision that in fact you did want competency restoration, we kind of laid out some of what have been identified as the best practices. Is that kind of what you were looking for? Mm-hmm.
Yeah, how, you said you were asked to consider restoring competency. How was that asked?
The legislature, it was in S91 last year, Act 28.
Act 28.
Okay.
Yeah, I mean, we had Act 27, which was one side of things, and this is a different bill, Act 28.
So they asked and we don't do it?
We did. We asked.
Oh.
We as legislators asked, should we have a competency restoration program in Vermont?
Okay, thank you.
So, and I asked Kiki to get the report up on our webpage because it wasn't there this morning, so let us know when it's there. It's there now, so if you refresh, you can find the report. And what would be helpful, any other questions for Karen? Okay, so what we'll do is maybe you could just very briefly walk us through the recommendations that are there in the report, what the thinking is on the part of the department. I mean,
Sure.
go ahead.
So just, I don't want to review too much what I did last time. So if I am, just let me know, but I'll just kind of basically first say how we kind of came up with the report. So I thought it was important to do a couple different things. One, to pull clinical expertise. I'm a lawyer. I don't know that stuff. So I depended really heavily on 3 clinicians. First is Dr. Greg Tomasulo, who's a licensed psychologist and the director of psychology and recovery services at BPCH. And the second was Dr. Keelan Garvey, who's the director of forensic psychology with Innovatel, which is the company we use to do our competency and sanity evaluations. But kind of more importantly for this, she practices across many different states and is on staff at Brown University. So she has a lot of experience in competency restoration programs in different states. I also spent some time and got some good information from Dr. Simi Ravin, who many of you are familiar with. I think she's testified in front of you before. She's the medical director of Howard Center, but more relevant for this, I would say, was the past president of the Vermont Medical Society, and she's on staff at Yale in Connecticut, certainly does a lot around competency restoration. So I kind of pulled from their expertise to pull kind of clinical data about how competency restoration works. We looked at both for those with mental illness and those with intellectual disabilities. And then the other two things we really looked at was there was a lot of work done at the national level on this, because as I said, Vermont is kind of an outlier in that we don't have a program. Most states have them. There's not really any consistency across the states, though. Some work better than others. So there was a lot of work done to kind of think about what are best practices for states to implement competency restoration. So I kind of looked at two main reports for that. The first was a 2020 report from the Council of State Governments Justice Center, and that one was called Just and Well, Rethinking How States Approach Competency to Stand Trial. And there are links in the competency restoration report to these if you want to spend some more time. But the goal of that report was really to kind of re-envision what competency restoration looks like, making sure it was really reserved for cases where the criminal justice system had a strong interest in restoring competency. And so that report kind of put forward 10 strategies they thought would make for an effective competency restoration program. About a year later, in July 2021, the National Judicial Task Force to examine state courts' response to mental illness published a report called Leading Reform, Competence to Stand Trial Systems. And they did that as a resource for state courts. And what they went through is that's an organization that's comprised of chief justices from all states, all 50 states. And they kind of talked about best practices and identified 10 best practices. So we looked at both of those reports, and then we looked at the clinical evidence, and then we made some recommendations. And so basically what we found was that competency restoration can and does work when it's done correctly. Most states do have programs, and admittedly, many of them don't do them well, which is why there's been such a focus to think about how do we do them correctly. And I think that's one of the reasons why Vermont is in a good position to think about this, because a lot of states are in a position where they have a program and they need to make a lot of changes to the program to really meet best practices. Where Vermont, because we don't have one, we can really build it from the ground up and only really think about best practices when you're creating it, if you so choose. So what do we really think if you're going to design a program? What are some of the things that are important? To limit it to serious crimes and the cases that are inappropriate for
Karen,
yes.
Karen, I don't want to interrupt the flow because it's really great. I'm looking at the executive summary. Yep. If we follow through on the executive summary, beginning with program design, is that going to be where you will? Are you directing your comments there from there?
I just have my own notes, but I can certainly, I can pull up, I'm sure it's probably the same. I can pull up the report too.
It's similar, so far so good.
Okay.
So I know in the report, the whole report is 796 pages. So
it's long. It's a long. Right, the executive summary is really where it's at though, yeah.
But that's even longer than the library report.
Okay, thank you. So, didn't mean to interrupt the.
No worries. So again, limiting it to serious crimes and cases that aren't appropriate for dismissal or diversion. I think a lot of the focus on best practices is really diverting cases out of the criminal justice system that don't need to be there. We really think that makes a lot of sense. We certainly see cases where we're wondering why they weren't diverted. The goal of the mental health system is to always get people where they're at, right? To get them services and to keep them in their communities. And so ideally you're doing these on the front end, or if they do have contact with the criminal justice system, if there's a way to divert them out and actually get them that treatment, that's always the goal. And so, we have worked some with the diversion programs to kind of talk about how do we make sure people are being diverted. But In some states, and one of the things that came out of one of the reports was to actually limit who could even get competency evaluations and to really put more structure around when you divert a case. I think in Vermont, my understanding is that like it's really a decision by the prosecutor. And so in other states, they've made a policy decision to kind of really provide more guidance and take more of an active role in which cases are diverted. So, but trying to divert where you can. Another big thing was to conduct evaluations and restoration in the most appropriate site. And we kind of talked about that in the beginning, which may be a healthcare setting. It could be in DOC, or it could be in the community. A lot of states, people go to the state hospital to get restored to competency, but they don't really need that level of care. That's a very restrictive level of care. Just to note, most other states are general fund hospitals, which is why they can put people who don't meet clinical criteria in a state hospital. In Vermont, all of our hospitals are Medicaid funded, right? So they are CMS certified and Joint Commission accredited, which means in order to take and use that funding, there has to be a clinician, an admitting physician has to certify that a person meets that level of care. That's different than a lot of other state hospitals. So I just want to, sometimes that's confusing, but that's why most states use state hospitals for restoration. But best practice, yes.
Good, quick question on that one. So if the person is in the system, in the court system, are in other states, then there are facilities waiting for these folks to be referred. So the judiciary would know where to send folks.
Yes.
Yeah, so it'd be designated and they would be supported with resources.
Yes, there have been some lawsuits across the country where there's often waiting lists for these programs, and so people may remain incarcerated while waiting for a program, which is why there was such a focus on really limiting competency restoration for the most serious crimes or those not eligible for diversion. So you don't have those long lists, but instead you're focusing resources on the cases that it really makes sense to do competency restoration on.
Okay, and there are a lot of questions embedded in all of that. Yes, got it. Thank you.
Let's see. Developing high quality and equitable evaluations and restoration services. So again, making sure that wherever they're getting competency restoration, they're getting the same type of program. Developing and imposing rational timelines. That's a real problem in some other states, right? People could be waiting months for competency restoration, and in some cases, people could be waiting longer to be restored than they were facing for the original charges. So we think it's really important, if a competency restoration is designed in Vermont, that there be real clear rational timelines. How long can someone remain in a program? How often are they reevaluated? So giving some real clear structure around the program. Using data to inform decision-making and system improvements. One of the things we did really hear as we were talking to other states is having some clear guidance, also being a bit flexible, especially starting off designing a program so that it can be adapted if you're seeing data or something is happening that you can make the adjustments, but really kind of focusing on what the data is telling you is important. And to really create quality clinical programming. And so in some states, the focus is just on education, right? So who is your attorney? Who's the judge? What are their roles? That kind of thing. And that's restoring you to competency. But really, it should be a mix of clinical programming, making sure that they're getting whatever clinical needs they have met, in addition to providing that education. So we feel, and what people have found is for best practices, there should be a focus on both. It shouldn't be one or the other, but instead it should be a really integrated program that focuses on both aspects of it. Part of that is evaluating in a timely manner, including determining when someone isn't restorable. And when someone is thought to be restorable, putting timelines or potential timelines around that. So what we kind of envision with that, you know, when a person was initially evaluated for competency, the evaluator would not just be saying competent or incompetent like they do now, but if they said incompetent, they would also make a recommendation as to whether or not they felt the person was restorable. And if so, what a realistic timeline for that might be. And at the end of that timeline, if the person wasn't restored, making a determination as to whether or not they can't be restored at that point, or if they think a certain amount of time additionally could be helpful, but kind of really putting clear guidelines in there about making sure there's always a clinical basis for it. And then reevaluating is a really important component of programming is what we found in best practices. So those are kind of, if the legislature made the policy decision to do it, those are the big things that we thought would be a part of a program that was really utilizing best practices.
So, right, thank you for that. I mean, the report is really pretty comprehensive, and we appreciate the work that you've done on this. And unfortunately, we received the report at a time after we're drafting legislation, or we could get together with folks, with you and judiciary to put anything into legislation. I'm not sure what we can do at this point. I think it's important to follow up on the good work that you have done. So we'll have to put our heads together and think about the best way to proceed. I'll also reach out to Senate Judiciary to understand thinking on that side. I don't think they haven't taken this up yet. They haven't looked at the report as far as I know. So we'll, but this is an important, this is a huge, it's a huge step, and it's critically important. So any of your thoughts that you've had in terms of how to move this from a report to a program?
Yeah, so I think that while I do think that there's some things that maybe could be thought about now in terms of maybe a medication piece. So in terms of the importance of medication and competency restoration, you know, data-wise, it is a part of, often a high percentage part of people who are restored. And in addition to that, we had also been asked to, or we have also asked to be able to utilize medication in a potential forensic facility or a secure facility, you know, like River Valley, which we had talked about initially, depending on where the legislature is thinking on that. So kind of continuing that medication discussion, even just in terms of doing it in the forensic facility, I think is a part of it. Because even though they're separate, in some ways they are tied together. So I think kind of continuing the forensic facility discussion, again, while they aren't linked, is kind of an important component of continuing the discussion on competency restoration.
Yeah, so you're talking about involuntary medication in particular, perhaps for folks who are waiting for trial, or if they become competent to stand trial through involuntary medication.
So both, I guess. So when we're looking at for the forensic facility, you know, right now we are really only doing involuntary medications in hospitals. But what we see is that some people could transition to lower level of care if we knew they were taking their medications, right? Like that's an important component of their stability. And so when we're looking at creating a forensic level of care, or we're looking at how do we really utilize River Valley in a way that's effective, we think that kind of rehaving that conversation about court-ordered medications as a component of those programs would be helpful. In addition, there is a component where if we were thinking about doing competency restoration, involuntary medications are often a part of that. And what's talked about in the report is, does it make sense to consider a slightly different standard for those individuals than people just purely in the civil sense, right? So purely just kind of in the forensic facility or River Valley, just kind of for treatment purposes. If we're thinking about it for competency restoration, there has been some case law at the federal level that has kind of flushed out standards for involuntary medications in those cases. And it's different. It's a little different than what we do now for our folks. So I think it makes sense to kind of have both those conversations.
Okay, thank you for that. And then one comment then, it would be helpful to get your take on any language, supportive language for that forensic facility and medication. And perhaps connecting with Katie, obviously with us here, but through me, we can start with that. And then perhaps Eric Fitzpatrick, so I'm looking at Katie and seeing if that's a possibility. We can get some language together that might
Absolutely
help move us forward without having to do the whole thing. It's huge.
Absolutely.
Okay.
Yeah, I can do that. I'm happy to work with Katie on that.
All right, that'd be super, because I do want to take a step forward, and I know that this is a lot right now, and there's no way we're going to sort ourselves through it. There's no, it's not going to happen. So, okay. Senator Harvey has a question.
Thanks, Madam Chair, and I thank you. I agree. I was like, oh my God, if we have to try to do a bill on this session, I will lose it.
I kept nagging them to get this report, but now I'm glad I did.
Yeah, but I think that I do agree that we could probably put some things in the forensic facility bill that would move it forward, and then, you know, everybody commit to coming back to this with a bill next session. I have a basic question, Karen, which I'm certain has been answered already, but I just need a reminder. Competency restoration is often temporary, right? It's not like you get, a person can be restored in order to stand trial, but it's not a permanent, okay, they're quote unquote better now, right? Is that, I see some nodding, and the Morning Fox is nodding yes, but I just wanted to confirm that. So often there's involuntary medication that can restore somebody's competency for them to be able to stand trial, but then after their trial, so what happens?
So it depends, really. It depends, why are they incompetent in the first place, right? So if it's substance use and they don't, you know, they regain competency because they're in a place where they're not using substances, and they go out and they use substances again, it could certainly impact them. If they have a mental illness and they're treated effectively for their mental illness, that may restore their competency. But if they later choose not to engage in treatment, then certainly they could become incompetent again. Again, incompetency, though, is a legal standard, right? So it's really only relevant for trial. It's, can you proceed to trial? Your underlying kind of medical issues could certainly continue. Although if you say we're found guilty and we're in corrections, corrections does have the ability to kind of provide mental health treatment, substance use treatment. They have MAT and corrections. So there are certain things that can be done, but it really depends on the underlying clinical reason for the incompetency.
Okay, thank you. That's helpful.
Mm-hmm.
Other questions for Karen? Okay. Well, you've just filled our brains again. We appreciate that. And
No problem.
so I think the next step is to have some recommendations, working with Katie and perhaps Eric Fitzpatrick, and we'll try to put something together. And in the meantime, I'll be talking with Senator Sears and to get his take on this. May get connected with him as well. That'd be great.
Okay, sounds wonderful. I'll follow up with Katie right after this.
Terrific. Thank you so much. And she's sitting right here, so.
Oh, okay. Katie, I'll email you.
We're good. Katie, did you want to add anything for us at this point?
No, I think there are some policy decisions for the committee to make if we want to move forward, but in terms of understanding the concept, no.
Okay, all right. And perhaps the policy decisions will come as we look at prospective language. And I know you and I have talked about this before. So there's some big decisions to be made. Okay. All right, thank you. Take a deep breath for that one. All right, so we're going to move on to S-189. And Katie, do you want to give us the high level? I think we've been through briefly with this one.
You have.
And so do you mind just giving us the high
I
level?
don't mind.
It's okay.
Pulling out my draft.
Okay.
I was jumping up here. Do you want it on the screen or do you have it on your?
We have it on our iPad.
Okay. So Katie McGlynn, Office of Legislative Counsel, S-189 has to do with protocols for mental health response services, both crisis services and non-crisis services. So really what you have is a new section in Title 18 with all of our other mental health laws, and it's broken into two subsections. The first subsection pertains to municipalities and it directs the Department of Mental Health to develop protocols for use by municipalities, including emergency medical technicians and public safety personnel who are employed or under contract with the municipality. And the protocols are to prescribe best practices for de-escalation for mental health response services, including crisis response services. And the department is to distribute those protocols to municipalities and publish them on the department's website. And then in subsection B, we have similar language that the department is to enter into MOUs with any state entity that's providing mental health response services. And those MOUs are to be consistent with the protocols that are being established for municipalities. That's it.
No, this is one that sounds the S word, but is really complicated. Yeah, and we've heard back from folks already, so we'll take testimony. Is there a question here?
Well, just a comment. This overlaps with work that the GovOps committees do on training for police and other first responders, and there's a bill being worked on in the House. So I'm just a little bit concerned of.
So here's sort of the underlying
this
principle here is to ensure that the work that's being done is consistent with mental health practice. And so having Department of Mental Health establish some support information. We're going to hear the word guidelines coming up. I see Nicole. So let's hear the testimony and then we'll see where it goes and we'll take it from there.
Yeah, okay.
Okay,
I feel
Nicole.
like folks have already stole all my thunder, so you kind of know
I'm
everything that's coming.
apologize.
No, it's totally okay.
But no, it came from you in the first
And
place,
I
so I
am
didn't steal it. I mean,
I'm gonna-
give attribution.
I'm gonna share my screen just because I really like slides.
Okay.
So I'd like to help. Okay, perfect. Okay, so for the record, my name is Nicole DeStasio. I am the Director of Policy for the Department of Mental Health. So I'm here to talk to you today about S-189 that Katie just gave us the quick walkthrough. So I really want to start by saying, like, I think this is a very needed, and I think you've identified a real problem that we have is that in the face of emergencies, our municipalities and first responders are dealing with an absence of standardization and guidelines in the field when crises arise. And this has resulted in having different responses to varying degrees, and they're not always managing the situations as well as they could be potentially. And so the core of this problem, as we see it, is that there is an urgent need for a standardized approach that has been crafted by mental health experts that can equip our responders with the knowledge and skills necessary to address mental health emergencies confidently, effectively, and compassionately. And so I think that is what the goal of today's testimony is, to talk about how we can achieve that goal. So Katie did a wonderful job of doing a quick walkthrough. So I am going to skip this slide because she already kind of went through what the bill says and just kind of move on. But I also want to acknowledge that the feedback I'm going to present today is a result of really just a team collaboration. Some of whom folks are in the room here today if there's questions or concerns that come up, but this has really been the Department of Mental Health, the Department of Health, and the Department of Public Safety has worked on this feedback together. We also would suggest some additional partners before we finalize legislation, and that might be representatives from the municipalities, Vermont Fire and Police Chiefs, and the EMS Advisory Committee. But it's also possible you've heard from those folks already. And then just a quick reminder of when we're talking about emergency medical services protocols, there is an established practice in place already that's really guided by the EMS physician director, and that development of any protocols is a really collaborative and iterative process, and that the health department right now is solely responsible for developing any protocols related to EMS providers, and that there would be a concern issuing protocols from the Department of Mental Health where people in the field don't necessarily know who is the right oversight body. So, but I think you already know where that's going. So we would really recommend not using the word protocols. The word protocols in the field is really the standard of care, and it's something that emergency responders are held against as best practice. Not as just as best practice, but really as like if you have not done
Accountability.
yeah, you could be subject to disciplinary action and other things. And so we would suggest either using guidelines or toolkit or something that. Yeah, depending on how.
I like toolkit.
I actually really like toolkit as well. That would be my personal preference, but yeah, just something that other than protocols. But Madam Chair, definitely defer to you on what specific word you would want to use. The other thing we'd suggest is not requiring a memorandum of understanding. So just just to kind of level set, a memorandum of understanding is an agreement between entities that establishes mutual expectations and commitments. It's a non-binding, non-legally enforceable set of expectations. And that there's generally outlined expectations from both sides. And in this situation, we're really talking just about expectations on the state side of what we need to do. So we would suggest, at least for now, not requiring the memorandum of understanding in the legislation.
Can I ask about that? What do you mean that you're just talking about the responsibility on the state side? Isn't there responsibility on the local level to follow the guidelines or toolkit, use the tools in the kit?
So I think that is at the discretion of the legislature how you'd want to set expectations for accepting of things. And so again, that's part of the reason why I really think the word toolkit might be most helpful there, because then it's just something that people have available for access rather than a certain requirement of what they need to do to on their side. But you know, I think you can also talk to the folks in the field about what they think about whether they would be willing to accept an MOU or sign an MOU. But the state doesn't have any way of forcing someone else to sign that agreement too, which is another complication here.
Yeah, well, I mean, you can look at it in two ways. One, you can look at it as a mandatory responsibility for which you're accountable. On the other hand, what I'm hearing all the time from folks is, you know, what do we do? How do we de-escalate? How can we respond to this mental health crisis when we get there? And I hear from my local guys and other folks from across the state. So if you have that information available for them, then they can go in and have perhaps a better response.
Mm-hmm.
Well, and in addition to that, I mean, I'm hearing that too, but I'm also hearing like even more disturbing situations where law enforcement is saying, oh, this is a mental health issue, we're not gonna go. And then they're telling the mental health agencies, you go, this is a mental health issue, not a law enforcement issue. And in some cases there are firearms involved. And so it's putting the
Compound fracture.
Mm-hmm.
Yeah.
It's making it really unsafe for our frontline mental health workers. So I do think there needs to be some requirements and saying, you know, if these things are involved in the situation, law enforcement has to go. It is not
Right.
optional to say, oh, it's mental health, not our problem.
Yeah, I mean, this is a conversation that we've had in the past about DCF workers, and when they go into a home, when do they have law enforcement with them? So there's some consistent issues there. One of the things we might want to consider, and I don't know whether you've considered this in your thinking, Nicole, is some of the things that should be in the toolkit. I mean, consistent with what Senator Hardy's just said, or perhaps what Morning Fox can share with us at some point, around public safety in particular.
Yeah, I also will remind folks that we just had the mobile crisis launch on January 1st.
Yes.
And those are, those are folks who are intended to respond to mental health circumstances, instead of police. So that really, we haven't really seen the impact of that just yet.
Is that statewide? I can't remember.
It is, yeah,
Okay.
yeah.
Oh, yeah.
And so.
This is based on there was the pilot in Rutland, and this is the
Correct,
expansion of that.
correct.
Yeah.
This is expansion across the age span and across the whole state. And I know in the first week, they had about 55 to 60 calls that they responded to. I don't have any updated numbers, but it did launch, it is statewide, and it has been. So there's also that component too, that I don't think we've seen the impact of for response to mental health crises.
So,
Yeah, okay, so I'll just kind of go through, this is what our recommendation is for some markups on this bill, is to, again, I'm leaving that open here of switching it to really guidelines or toolkits. And then I would suggest at least for now, to strike that last one, or at least rethink and rework it after you've had some conversations with the field. But I think for now, our recommendation here is to strike this. I also will say too, is that we're really lucky to have a crisis director that came with the mobile crisis response. So we just have that new position now, and we really think that this is a good area for our new crisis director to really be able to direct what these guidelines or this toolkit is.
so maybe you could let us know who that person is, and we can invite them in.
Absolutely.
Okay, and then you're suggesting that person would take the lead in developing the guidelines and the toolkit?
Correct. Developing, distributing them, and potentially, there may be opportunities to work with people in the field, do training. So I think that would be a good opportunity for, his name is Jeremy Terrian, I'm just saying that person. He is our new crisis director. And so we're very lucky to have him. He's got a significant amount of experience in the field. He's new to the he's relatively new to the Department of Mental Health, but he's been working in Vermont in the field for a really long time.
So if you give his contact information,
Absolutely.
Kiki, we can have Ben talk about that. I know we've had this conversation in prior years with another bill, and I know Maureen Fox was here, and we talked about it, and I'm gonna have you make comments today if you want to, or we can do it another day. But I do see this as a really critical issue, and having the umbrella of Department of Mental Health over the response that takes place. And it could be more than mental health. Substance use disorder, looking at.
Absolutely.
Yeah. We may want to fold that in some way. So Senator Gulick and then Senator Williams.
I'm not sure if this question is who it's for, but we often see these great documents get made and distributed, but then they actually don't get in the hands of the right folks, and the training doesn't occur and all of that. So minus the MOU, I mean, how do you envision it actually getting into the hands? I don't.
That's
It's a
a good
problem.
question.
Yeah.
And so maybe that's where GovOps can help us. How do we distribute?
Well, that's what I think we need to hear, and this is my concern about it being integrated more with what's going on with police training, as in particular, is the Vermont Criminal Justice Council.
Right.
Part of their work is to train law enforcement, and they have a whole curriculum on how to do that, and that includes some de-escalation work. So wanting to make sure that this is consistent with what they're doing, and also if we do pass this, that they integrate it in appropriately. That it's not just a suggestion, that this is really something they need to do. So
Yeah, and so it could, I agree with you, and we did have, is it Kristen Anderson, who's the person in charge of
Kristen
it?
Chandler.
no, I'm completely blanking on the name.
Anyway,
That
we did have her in last time talking about this issue. And the work they're doing is outstanding, it's amazing. All we're talking about here is something you carry in your hip pocket when you go out, or when you're, as a fire person, the first responder, whether it's fire or EMS or public safety, has different level of training on this. And so that's why I wanted to have morning talk, but we'll go through this. I think you're right, it can't be separate, it needs to be together.
Yeah, and I would like to check in with the House Chair, because he's working on a bill on criminal justice council, and so
We
wanting to
can do
make sure
that,
that.
we're gonna do ours. Well, we're gonna do mental health, but we'll ensure that we have some linkage, and that would be helpful. It would be helpful, after you check.
I think we're missing a step too, because it's gotta start with dispatching. So somebody to understand the situation around with an EMS in Chittenden County, and the municipality that they work for actually set up that EMS would not roll to the scene until it was secure.
Yeah.
And the dispatch needs to understand the situation to know who the right people to call. So it's kind of a systemic issue.
It is,
Right.
it's getting
Thanks for
worse.
mentioning dispatch. Woo! Yeah, I totally agree. After all the work we did on dispatch last year, like
You're right.
they have to know who to send.
Yeah, and I know we are definitely training, again, when it comes to mobile crisis, the 988, but I would actually defer to Maureen Fox to talk about anything related to, the public safety side and what they have in place.
It really almost is a protocol, because, I understand why we don't wanna call it a protocol, because there could be some punishment involved with it, but that's a good teacher. If somebody isn't properly trained and they make a decision and somebody gets hurt, then maybe they shouldn't have done what they did.
Yeah, I agree. I do think these are,
Yeah.
if we're gonna do this, we should do it, we should make them protocols, but there are already protocols that exist, and that's where I'm wanting to make sure that we're being consistent with those protocols.
Thank you. That's all I want to say.
Definitely happy to talk more.
Right, but we definitely need the overlay of mental health and substance use disorder, appropriate treatment of patients when they're out there.
Yeah. Even just to give folks the confidence to respond in the field.
Yes.
That may be some of what's creating the hesitancy, is not feeling that they can confidently,
Yeah.
actually engage with that. So I completely agree. We're very happy to be at the table and work with you on this legislation.
No, I know, it's one thing to be called to somebody's home because a senior citizen has fallen, and it's another thing to be called when you just don't know what's gonna meet you at the front door. So,
And, you can be called to a scene because of a mental health emergency, or just by the nature of the first response. A mental health emergency, a crisis can just, evolve on the scene related to whatever that response is.
Yeah.
So.
So let's Morning Fox is here, and Brenda, did you want to make any comments? I'm gonna have to bring Morning Fox up, and then we will talk with each of you about next steps in terms of who to have in, and make sure that this doesn't conflict. You can come up, doesn't conflict with what's going on in other areas, but I think it is important to have the mental health folks involved in this, as well as substance use disorder. I'm looking at Brenda. Okay. And co-occurring.
And intellectual.
Good morning.
And developmental. And
Yes, I know.
Good morning. Thank you for having me, Madam Chair. Thank you for the conversation the other day. For the record, my name is Morning Fox. I'm the Director of Mental Health Programs for the Department of Public Safety. So my comments today really are in support of what Nicole was speaking about earlier. We had talked about this bill earlier. We met to discuss this with both members from Department of Health as well as Department of Mental Health, and myself and a member from the state police, one of the captains that I work with. And I think Nicole outlined some of the concerns that we have, but just to kind of hammer down a little bit more on some of that, I can appreciate the concern of if the guidelines go out, how do we ensure that the right people are getting them and or doing what's recommended or suggested or is available in said toolkit. I guess the thing that then we'd have to look at, which would make this bill go from 1.5 pages to several more pages, is going to be who monitors who's using this information and how, what is the enforcement entity, who is that entity, you know, because we're now talking about mental health guidelines, toolkits, but we're talking about law enforcement, we're talking about fire, we're talking about EMS, we're talking about dispatch, you know, all these other folks who are involved. And, you know, so what entity kind of oversees that? Is it multiple entities? And, you know, I think we know enough about state government. When one entity is involved, it gets complicated. Let's throw 2, 3, 4, 5 entities together, and not even all of them are under AHS necessarily. Whose toes are you know, are being stepped on, and how's that going to play out? So I think that's stuff that if we're going down that road, you know, how does that play out? You know, so are we speaking of these toolkits or guidelines or protocols mandatory for every municipality out there and every entity doing this work? If so, is there going to be, you know, funding attached to this? Because there are going to be smaller municipalities. Okay, you've got to train all your folks in what's being recommended here. Well, we need the money to train our folks, and you know, those kind of things. And so where's that going to come from? So there's a lot of moving pieces to this. Using the S word, as you said, Madam Chair, it's much more complicated than it first appears. And so these are some things that I just wanted to kind of first address and kind of go, how do we play this if we're going to go down those roads? That's why for me, I really do prefer meeting with all of the various players, having the Department of Health, having Dale, having public safety, having folks from, you know, chiefs of police and, you know, local law enforcement, as well as public safety, criminal justice council, EMS, peers, you know, people with lived experience. If we're talking about protocols and guidelines, toolkits of how to respond, you know, for mental health emergencies, should not their voice be heard as well in part of this, especially here on Mental Health Advocacy Day? You know, and so, you know, how do we put this all together? I think is a you know, a concern. So, you know, I just wanted to kind of put that out there, that there's a lot of moving pieces here. And I appreciate Senator Hardy bringing up the bill in GovOps and how does that interplay with this too? So now I have to go and go, well, what bill was that? So I can start to review that as well.
It's a committee bill, so I'm not sure the number yet.
Okay, so these are just some of the few things, just kind of off the top of my head as I'm listening to Nicole testify, and based on some of the conversations I've had with other folks, operationalizing this in a mandatory MOU fashion could become very arduous and difficult, as opposed to let us work together, develop these toolkits, bring in members from around the state, and then here is information. Here is recommendations. You know, if you're going to have emergency response, you should have, you know, some type of, you know, de-escalation training, which could include this, or this. You know, that kind of thing, but it doesn't necessarily be prescriptive that you have to use this, you know, particular type, you know, things of that sort, because there are varying types out there, and it's one's personal opinion and subjective to say this one's better than the other. And so to be prescriptive to all 100 and some odd, 151 towns and municipalities throughout the state,
I know.
you get my point. Okay, so I will stop there. And I will leave it at that, but if there are questions, I will answer them gladly.
So what we'll do is, I mean, this is the first look at, you know, folks from from you and Nicole and Department of Mental Health. One thing I would love to say about this is I put the bill in, and this has been something I've been concerned about for several
Oh, yeah.
sessions, you know that.
Oh, yeah, we've talked about it many
We've talked
times.
about this many times, and now it's gotten to the tipping point, as far as I can tell. There's been a critical mass of issues out there that we need to respond to. And, so we don't want to be too late to the game. However, saying that, I just want to thank you, each of you, for taking this, to this level, to bringing it in, seriously to help move the legislation along. But what we'll do is we'll continue to take testimony, but it needs to be a short form testimony because I think we can make this work. And as you said, we need Dale, DMH, Department of Health, all folks together in making recommendations that we can put together that will help folks when they respond. So we'll stay connected with other committees that are doing their work. I mean, obviously, this is more of what are the appropriate, what's the appropriate information? I'm not gonna use guidelines or protocols yet. What's the appropriate information available? Responses taken place. Thank you for being available.
Thank you.
To each of you, and I do appreciate the work that you've done on this outside, the conversation that it has stimulated. I mean, that's the good news for me. And the next step is, what is the VLC talking, CT talking about?
Right.
I chaired my select board for 10 years and I know the difficulty of getting one town
Right.
coordinated, so having all of them.
And so having the Vermont League involved in this.
Yes, would be
early-
great, yeah. Okay, thank you.
Thank you all, appreciate
So
it.
we're right on time. And so what we'll do, is we're gonna give the room a chance to change over to S-151 and Jen Carby should be with us. And we're gonna take a 5-minute break to